Now, earlier, I sat down with Val Schott, who's the director for the Center of Rural Health at Oklahoma State University, and talked with him about what other communities can learn from the town of Drumright. Well, Val, from early on in my career, it seemed like I was doing a story on a rural hospital closing like every year. But in recent years, it seems like that has slowed down. Why is that?
That's exactly right. About 6 years ago, Congress passed what we call the Medicare Rural Hospital Flexibility Act, which allowed small rural hospitals, the smallest rural hospitals, those that are 25 beds or less in rural communities, to become critical access hospitals. And essentially what that does, it pays them 101% of their costs for their Medicare patient base. That's significant because that's 60 to maybe 80% of what their payer source is for most rural hospitals in Oklahoma and in other parts of the country as well.
So in addition to the changes that have been made on the federal level, how has technology helped these hospitals survive and even prosper in some areas?
Well, that's a really good point. When a hospital administrator had to look at how am I going to make payroll for the next 2 weeks, and that's what the prospective payment system really did to those rural hospitals. They couldn't look at making any improvements in their technology. For instance, the radiology, in order to have current state-of-the-art equipment, it costs probably $90,000 plus for a rural hospital to do that. If you have to make payroll every 2 weeks and are concerned about that, then you're not going to look at putting money into the capital structure.
And as we just saw in the Drumright story, these are smaller facilities, more targeted facilities as well.
Exactly, and they're built to take care of their primary care needs for people in those communities. Now, that's not to say we're going to do everything in rural hospitals. We're not going to be cracking chests in every rural hospital in Oklahoma, or probably none of them, except on an emergency basis. But we can do 60, 65% of all the health care that people need in those small rural primary care hospitals.
Yeah, we've talked a lot about technology, but I guess it warrants to say rural physicians are extremely important to make any of this work.
Absolutely. Our mission is to provide rural primary care physicians for Oklahoma, and we do a really good job of that. We're the only medical school in the country that requires their graduates to take a telemedicine course. I'm really ashamed to say that. I think every medical school should do that. But our guys and gals, and they're great kids, they're great doctors, have to take a telemedicine course before they can graduate, have to make a presentation actually using telemedicine to do so.
Mm-hmm. Have the partnerships developed between the smaller hospitals and the larger hospitals that they're doing this telemedicine with?
Absolutely, absolutely. They look to the larger hospitals for part of their for specialty referrals, those kinds of things. We're doing cardiology follow-ups through telemedicine. We're doing some psychiatry through telemedicine. We just really scratched the surface there, but it gives a natural referral pattern for those types of situations, and it provides it ends that isolation that a rural doctor would feel.
Mm-hmm. Final question, what do you see the future being like?
Well, I think we're going to see more and more of telemedicine, quite frankly. We're going to see the physician as the person that manages that care. We certainly will see some physician extenders in that process, but we have to find ways to keep that primary care physician in that rural community. That's the key, in my view, is to have primary care available in those rural communities.